This is the ABQ Business Podcast with your host, Jason Rigby. Each week we'll interview visionary business leaders to inspire the creative power and spirit that's in every entrepreneur. Discussing strengths, weaknesses, strategies, systems, and the problems we can all solve together for a new future for local small business.
So you mentioned right care, right time, right provider at the right cost. We just talked about the right care. What do you mean when you say time?
So that's the access part, right? Because, when that consumer or that person goes to get the care because, I have this strep throat, or I'm having these palpitations, or I'm having this small issue, that's the right time. Because if they don't go in, maybe they forget about it. Maybe they get busy. And then it can get worse. It can exacerbate. And so the right time is when they feel
when they need it.
That they're having a problem.
Whether it's
you go into that with direct primary care, like right time, because your time is different than.
Oh,
you're
right.
Not doing
Yeah.
sick
So
care, you're doing health care.
When we onboard a company, we reserve slots and time to get those employees in within that month, that first month that they're enrolling. And so it's not a 6, 7, 8 month wait to get into a primary care provider. And even if they're not in within a week or two, like the official appointment, if they need a refill, if they have a sore throat prior to their first appointment, they have immediate access to the clinic. There is no delay. We're not waiting for that first appointment, but we do make sure that employees get in within that month that the company onboards. And so, of course, that's the right time. Like, they need to get established not 6 months from now, kind of now, but when they have that sore throat, when they have that fever, they need to be seen that day, or at least talk to somebody that day. And that's what we do. Like, we reserve slots for same day sick all the time. There's slots reserved. It's never filled until that morning or maybe the afternoon before if somebody calls later in the day.
So when you're talking about efficiency, with an employer and being able to, prevent a sickness that could take them out for 2 or 3 days, where they could come in right away and get that solved.
That would be the idea. We can't always guarantee we'll get them back to work the next day, but it's better than the system that they're probably currently having access to. Or it could be an urgent care visit or even an emergency room visit that's going to cost this employer far more than it needed to.
Yeah.
So what happens there? I'm curious about that. So what if somebody cannot find a clinic open, so they just decide to go to the emergency room? Because you see that all the time.
Yeah.
That costs the employer?
It depends on the way they're structured, but yes.
The way that their health plan is structured, whether it be level funded or self-funded, that could go toward their utilization and then drive their premiums up for sure. The other issue is that, we only have so much capacity in the emergency rooms, and that should be reserved for true emergencies. But also, people don't need to be sitting in emergency rooms waiting for basic care. I mean, and even sometimes when they're so congested that even sometimes when somebody goes into the emergency room to get the appropriate care, and they should be there, they don't get the appropriate care because they were so busy with just this congestion that maybe shouldn't even be there.
Yes. There's a lot of that. Yeah.
Yeah. My brother had a situation where he was just in severe pain, and he went to the emergency room, and I think the congestion or the perception or whatever they think, they just pass some pain meds and send him away. Well, within a couple of days when I saw him, I said, something's really wrong, bro. You shouldn't be hurting this bad. And I took him to my direct primary care at the time. This is prior to Well Life, and that direct primary care said, Angela, you must get him to the hospital right now. He is septic. He's got a matter of hours to live. And he'd been in the emergency room a couple of days before.
That's crazy.
Yeah.
Yeah. I've talked to physician assistants, doctors, nurse practitioners that's worked here locally, and they all say they're at around 40 to 70 patients in a 12-hour shift.
Oh, yeah.
So 70, think about that.
Yeah. When I worked in
an hour, no breaks, no lunch, no nothing.
Yeah.
And they're still backlogged.
Yeah. When I worked in traditional care, I could not, by the end of the day, remember who I saw in the beginning of the day.
If you're going through, like, how many do you see? 70 people in a day?
Oh no, a busy day for us would be about 10. It's a very, very different model. And the model, we're talking about how it benefits the employer and how it benefits the employee. So that's a win-win. but it also benefits the provider. And so one of the things that people talk about direct primary care is like, oh, you're limiting care. You're not giving access to everybody. It's only a select group. But the bottom line is that primary care providers are worn out. Like doctors are talking about retirement. They never used to retire. They like worked until they died. And they talk about early retirement, and more doctors, nurse practitioners, they don't even go into primary care. They're like, forget it. I'm only going to do specialty care. I'm going to go into education. I'm going to do this or that, but anything but primary care. I personally love primary care. I think it's great. It's kind of in people's messy lives and it's great, but I could have never survived it in the traditional model. Like I would have been completely tapped out, but now I see working until I die because I like it. So it's actually fixing the shortage of primary care providers because it is a more tenable solution for us to practice and provide good care. Because we don't get into this world of healthcare because we don't want to help people. Like we were wanting to help. We just can't when both hands are tied behind our back.
Yeah, and they've created this. I mean, we'll get into they here.
The system created it.
Yeah, the system, right care, right time, right provider, and that's what you're talking about as far as the right provider.
Yeah, the spectrum. If you look at the spectrum of healthcare, and health insurance companies have really tried to tackle that with they put an actual spectrum in their little booklets that says, okay, if you have fever, sore throat, that this is where you want to start first, where you want to go to first, maybe telemedicine,
nurse line or something.
The nurse line. And then it gets to other things, where chest pain and that's an automatic go directly to emergency room. Do not pass go. Do not collect $100. That's just the way it goes. Right. And so that is just an education piece that needs to get out more and more and more and me driven home. But when it fails at the lower level, at the basic level, when they have that fever or that strep throat or whatever, and they can't get into that basic level, then it just escalates on down the line. And then we end up getting congestion, like I was talking about, in those other areas. And it makes the system just like a dominoes up, falling and collapsing everywhere. So where we need to work is at the basic level and access at the right time.
And then save the health insurance for those emergency situations, catastrophic.
Yes. And then the other thing about the right provider is I'm proud to call us a medical home, a true medical home to people that are our members. And so they come to us and maybe we're not the right provider. Maybe they do need to go see a specialist, or maybe they need physical therapy, or maybe they need to go to the ER. Like, here we go. Let's call 911 right now. But we're a really good gatekeeper. And when the system works, we're a great gatekeeper to be like, okay, you're perfect right here. We can take care of you, or you need to go here, but come right back because we're your home. So come right back to us and tell us how it went. Do you have any questions about your specialist visit? Or maybe we can start managing your care now that you've had that one-time consult. And so just right back to us. We want you right back. And the model works for that really well.
Although I prefer to call it a gateway.
I understand.
Did you watch that on Cinemax HBO? Did you watch the people that all killed themselves? There was like 32 of them. They were like in a cult. And they thought that the alien
they
ship
drank
was
the Kool-Aid.
No, not that one.
This is a different one.
Jones. This is a different, a totally different one.
A new one.
But they have a 6-part series of documentary. But it's so interesting when I think it's Heaven's Gate.
I was like, where are we going with this?
No. But I mean, it's so interesting how people can buy off on something so easily. So you have a potential to be able to go to an employer, and you can feed them as much bullshit as you want. If you wanted to. And I know there's a lot of that goes on.
Yeah.
And so now they're just going to like you because they like you and they're going off of a hunch or a bias, which we know those are all wrong. And without any education, and they're just signing in and agreeing it. So the last one, when we get into right cost, this is where I want to get into. What are some of the things that you would love to be able to tell a small business owner that maybe you don't get a chance to sometimes because of this, especially when it comes to cost?
Or maybe you do get a chance to tell them, but there's not a solution.
The business owner, really, what they want to do is they want to help their employees because that's the backbone of their business.
That's why they're offering the benefit in the first place, to help their employees.
To retain the good people, to keep them healthy, to keep them happy, and keep them around, right? So if they cannot access the care, or if they do go access the care and it ends up costing them so much out of pocket that it really defeats the purpose of them even accessing the care, because then they're so stressed out about how to pay for, like for instance, I think the average cost out of pocket for an insured person for an emergency room visit is somewhere around $1,000. Well, hey, can we skip groceries this week? I don't know. No, probably not.
Right.
So that's where the employer's heart's in it, because they want to make sure that their employees are healthy and happy and can come to work. And the only way they can do that is by making it affordable, especially that gateway, that entry level care.
There's a dichotomy with that, because you have, you want to provide for your employees, but then at the same time, the cost is so
crushing.
Cost is crushing, especially if you have 20 people, 30 people.
Yeah.
I mean, think about that. And you're on these razor thin margins.
It can be crushing. And that's why copays and out-of-pocket costs for the employees have gotten so much higher, because the cost is just up. And then that leads to a whole other layer and level of broken systemness.
Broken access, because now an employee doesn't feel like they can go be seen because of this astronomical deductible. And so they're afraid to go get care, because like, is that going to cost me $20? Is that going to cost me $300? $1,000? What is it going to cost me? And most providers are like, we don't know, just wait and see.
And that's what they do. They tell them, hey, we'll just get in here and your insurance company will tell us how much it costs. That's like going in and buying a car and signing all the paperwork and taking it home. And then a month later, you get a bill for the car. And you're like, well, shoot, I wouldn't have paid that.
Right.
If I'd have known.
So when we get into cost transparency, you guys were talking about Cocoa Puffs. So I thought this was interesting. We shouldn't be eating Cocoa Puffs.
Right. Well, yeah, let's put that out there. Cocoa Puffs is not good for you on any level. I don't care what the package says, but it's not good for you. So yeah, I mean, cost transparency is a big part of why the healthcare system is broken, is that you don't know not only do you not know what the hip replacement costs, you don't even know what it should cost. And there's some solutions out there right now, but for the most part, that's what's happening. You don't know what it costs. And the analogy is the Cocoa Puffs. So you go to the grocery store, you've got Cocoa Puffs, 2 of them, right? And there's no price on either one of them. They're right next to each other. They're both the brand name. They're both the same size. Everything is identical. You pick the box up, you go to the cash register, and you don't even go to the cash register. You walk out, and then you get a bill 3 months later for, $450 for that box of Cocoa Puffs. But what you didn't know is the box right next to it was $3.50. And so had you known, you probably would have picked the box on the right. But you don't get to do that in healthcare. Like, good luck going to any provider that's not in this direct primary care kind of realm and saying, what is this going to cost me? They truly don't know.
That's where the transparency comes in. We don't have that. We don't have that in healthcare. We have that in everything. We have that in
everything.
You know what a house costs, you know what a car costs, you know what a gallon of milk costs, but you don't know what a hip replacement costs. You don't know what any really surgery costs. And that's the transparency that everybody's talking about. That's what we need to get out there and what needs to be shared, because they keep it all secret.
And without that transparency, there's no demand for lowering those prices to reasonable levels. There's nobody that can be like, well, no, I'm not going to pay $450 for this Cocoa Puffs because this one only costs $350 and it's the same thing. So if we had that transparency, it drives down costs. Every field that they've ever gotten rid of they've gotten cost transparency, it drives down costs.
How do you do that? Like with direct primary care and working with you as a broker, how can an employer see this cost transparency? I mean, obviously you can't. It seems like everybody's stuck. But is there a way that an employer can look at it and say, yeah, I don't know what the cost of Cocoa Puffs is, but I do know I can do this?
It's fixed. It's fixed. And they know exactly before they do anything what it's going to cost them.
Who does?
The employer. The member knows they can go and access for no charge. The employer knows they've got a fixed monthly fee for that.
Yeah.
I mean, that part is all fixed.
So direct primary care. Yeah. So that's fixed. So that's a solution to the cost transparency. Is like, here's a fixed cost for your employee every month, whether they're seen or not, whether they're seen 10 times or 0 times, it's one cost. Right. The employee knows $0 copay. I can at the very least, go be seen to be told my sore throat is just allergies and I should take my Claritin or my Zyrtec. That's all I needed to know. I don't need to go to urgent care for that. I'm fine. It's not strep throat, whatever the problem is or the concern. So yes, that part's fixed. But the hip replacement, the bigger stuff, which we're not really talking about because direct primary care really doesn't solve the bigger
exactly.
stuff. It does help with the gateway to say, okay, so it does look like we've sent you to ortho and they're recommending a hip replacement. Thankfully, you've come back and talked to us. And so now if we're working with an employer, we go to that employer. If they're the ones that are paying the cost of these things, we say, here's the cost. There's a surgery center in Oklahoma that's totally based on cost transparency. It's called the Surgery Center of Oklahoma. And you can go online and look up what does a hip replacement cost. So bigger companies actually send their employees there because it's cheaper and it's bundled. And that's the cost. There's no anesthesia bill 3 months later. There's no this person was out of network. Sorry, you owe this much more. It's all fixed and bundled. So companies will send that. But if you're not even going to do that, you're going to be like, okay, it's going to cost this much. I've looked this up on their website, and now I have something to work with locally. And I can say, hey, Presbyterian or Loveless, can you do it for this much? As an employer, you have bargaining chips. And so you can help drive down your own costs through that. But that's a little broken. That's hard to do. The easiest way is just send them to Oklahoma. But
yeah, well, there are some models out there, some health insurance, if you will, health insurance models that operate on that.
A fixed cost or a transparent cost.
On the transparent cost. Well, and basically saying it's you can go anywhere and it's a percentage of what Medicare reimbursement is. Mm-hmm. And I know that's a hot button to bring up, but they're called reference-based pricing products. Mm-hmm. And it's really, truly about advocating for the patient, mm-hmm. the one seeking care, and navigating the system. And so when they have that advocate and that navigator, that's like probably 3/4 of the battle. And then the next part is, how are we going to pay for it? How much are we going to pay for it? And then they negotiate that too. A lot of times even on the back end. But the direct primary care can do that chunk of
helping
navigate it, of advocating and navigating for them.
Because that poor HR person at the company, they don't know what a hip replacement costs. So they're just like, oh my gosh, what am I supposed to do? And so we can offer these solutions of try this, try that. Here's this place. It might even be cheaper, even with travel and hotel to send them to.
Yeah. And this knee has really been bugging me forever. Yeah. And I don't even want to go in because I can still walk. I can still function. It's a quality of life thing. Yeah. It's probably getting worse, but, nobody can tell me in the end what it's going to cost me. Yeah. It could be anywhere from my deductible of $2,000 up to my out-of-pocket max, which is $8,850, yeah. I don't know.
Yeah. Especially with everything that's going on now. Question, whenever it comes to an employer, or small business owner, and they're looking at when we talk about transparency cost, because I want to make sure people understand this, because you hit on something that's very, very important. When it comes to direct primary care, which is a big chunk of their employees, that part is ultimately transparent.
Oh,
now,
yeah.
how do you, because it's $75 a month period per,
right.
And then we'll get into medications here in a second, but how does that, so if I'm an HR person or I'm a business owner and I talk to you, how would you approach them with direct primary care as an add-on? And is it cost savings?
Well, first and foremost, it's about access, because that is probably the number one complaint you hear is people say, I can't find primary care. And then I get one and they leave. Or, I can't even get into one, or I did get an appointment with one, but it's 6 months from now. And that's just the environment that we're in right now. So first and foremost, it's that. Now, depending on, and that comes back to the employer wanting to, serve their employees with this, provide for their employees healthcare, good quality healthcare. Then it comes into, well, how are they designed? How are they set up? How is their health insurance set up? Are they self-insured? Are they level funded? Are they fully insured? Are they small group and they're just subject to small group? And really, if you look at the cost savings, it applies to all of them, because, how much is it worth to have your employees happy and healthy and staying with you and being able to be at work instead of being
Yeah, because they don't realize the loyalty proponent to that.
Yeah.
With the direct primary care, there are, you would kind of assume that would go hand in hand since my employer is paying this. And that's something too that we've talked about before. But even employees even small businesses, can benefit from this. It doesn't matter. You could have 3 employees. I know you don't get involved in, but what's the limit? What's the?
Oh, sure. We get involved from 2 on up. 2
on up. Oh, really?
Yeah. I mean, group technically starts at 2, but there's value in that. There's value in having happy, healthy employees that are able to work and be at their best because they have quality health care. And so that's really where the savings is there. And then also the actual employee not having to come out a lot of money for things they shouldn't. But then when you get further down the spectrum and you have hundreds or even thousands of employees and you might be on a level funded or a self-funded platform, all of those little claims, which are probably, there's the 80-20 rule at play everywhere, but I would say it's still like an 80-20. The number of encounters that occur is the 80%, the number of encounters, but those are all the very low cost. But they add up because there's many of them. All of that is going to be pulled out of and without getting too technical here, out of your claims fund. And that's money that belongs to the company. That's the company's money.
To the company.
And so if that is not spent on claims, then the company, keeps that or utilizes it for reinsurance or what have you. But it just makes sense.
So direct primary care can reduce claims?
Oh my gosh.
Yes.
So yeah, I mean, study after study is showing that for the most part, an employer that is paying their own claims, a level funded, partially self-funded, the different terms you use that I barely understand. But for the most part, they're saving about 30% right off the top. So if they have $1 million in their claims fund, they can expect to save $300,000.
Oh, that's amazing.
It's a big percentage.
So when you think of, let's say $300,000, that's worth a conversation.
Yeah, I would think so. And yes, it's hard. It's a paradigm shift. I mean, I'm working with a company right now doing a pilot study, and it's like little pieces are clicking into place with the decision makers. They'll ask a question and I'll answer it, and then a little light bulb will go on that they understand. Oh, we're bypassing the claim for that. Oh, it's still getting paid for. It's just a lot cheaper of what they're actually paying out.
And we haven't even gotten into that.
Yeah.
The cost efficiencies of not having to
file
for
the claim
providers
for every little thing
to go through and employ people to actually just
file a claim
just to get paid.
Yeah. Because the average, let's say $75 a month, they come in, maybe they're not feeling well that month. So they come in 2 or 3 times to your clinic. Each of those 2 or 3 times in a normal clinic would have been billed out.
Oh yeah. Mm-hmm.
So, I mean, that right there is that's one of the reasons on the cost savings.
That right there, cost savings. Yeah. There's other ways that lots of cost savings occur. We can get into that if you like.
Yeah, I want to get into prescription costs because if you don't mind, kind of go into that with the landscape of what currently is going on with prescription costs.
We'll let Angela take that one because the current landscape is a hot mess.
Yeah. So the current landscape is, again, it's another transparency issue. I tell all of my clients, to download a certain app that actually will tell you the retail cost and whether or not there are coupons out there or who has their special deals on what meds. So you can actually see what it's costing you. And if something's less than your copay, why are you going to go pay your copay? You wouldn't have to, but you're going to want to see, well, gee, is it cheaper somewhere? And they can range wildly from, I'm talking $10 for a 30-day supply up to $200, and it's the same box of Cocoa Puffs, right? Yeah. It's the same med. And it's just having the power, the education, the knowledge. When you start getting into the complexity of it with health insurance companies, they deal with PBMs, pharmacy benefit managers. And those pharmacy benefit managers make deals with the pharmaceutical companies, and then they pass on those deals to the health insurance companies. The health insurance companies create what they call formularies or drug lists that are their preferred lists, and those are going to cost the consumer hopefully less out of pocket, or drive them to those drugs because those are the only ones that are allowed, and therefore increasing the volume that is consumed of those drugs. But in the meantime, what's happening is the PBMs are guaranteeing certain numbers of sales to these pharmaceuticals, and then they're getting, basically rebates from the pharmaceuticals, if you want to call them that. And those rebates are going to the insurance companies. They get a little bit of a cut of that too. And that helps them, offset some of their costs and keep their book looking good. But that doesn't always get transferred over to, in fact, almost never does it get transferred down to the group.
Those rebates never go back to the employer.
They don't come back to the employer because it's not, number one, it's not regulated. Not that we want that, but it's not required, right? It's just a rebate. And that is some big money, right? I mean, there's a lot of padding in there that's unnecessary.
Well, some are even they're becoming together. Like,
they're all getting in bed with each other.
Everybody's
big time.
in bed.
Yeah, so if all three of them are they'll have a subsidiary that owns
each item.
Those.
Yeah,
and
so they're all falling in the same
you can
column.
all get together, and now you get a fixed pricing, and do a lot. It's basically only in healthcare. Any other system, we would call it illegal.
Oh yeah, we'd break
SEC
it all up.
would, if I
the rest of us call those kickbacks.
Yeah. Well, and
they call them
truly,
rebates, huh?
Yeah. Well, rebates. Truly, they've done some very despicable. Some people have done some very despicable things, and I think there's a real big case that everybody knew about. But there's a whole lot of cases that we don't know about. But the one was the EpiPen.
Oh my gosh! Yeah.
Where this man came in and basically it turned out that it was only one manufacturer of this EpiPen, in the nation, and they'd plugged along and done fine. And I think the cost of an EpiPen was something like $100. And overnight, someone or entity came and bought this, and you've heard, but they jacked the price up something like 500%. Well, automatically, instantly, every health insurance company, every person was forced to pay this 500% more just because they could. And I mean, that person actually did jail time because that was pretty wrong, but it's happening a lot.
Right.
And below the scenes where there's these generics that have been around forever, the cost of the pill is really not even, it's pennies. It's not even $1 or whatever.
The actual medication.
And the actual medication.
Cheap, yeah.
Well, they buy the one and only generic manufacturer because they can, and that's all that's left because there's really not a lot of money in it. And they rebrand it and they change it and they sell it, package it up and sell it at a heck of a lot more. But why is that necessary? That is
so
not.
that's the pharmaceutical company being diabolical, if you will. But the PBMs, greedy. The PBMs, they're getting all these rebates, but it even goes further. So they'll tell this pharmaceutical company that may have like 4 or 5 different drugs and say, we'll put that medication on our formulary and we'll put your other 4, even if they're not the cheapest option, onto our formulary if you give us X dollars back for rebates. And so as a provider, I run across this all the time. Like, I'll prescribe something and I know that is the cheapest, most appropriate option for that, whatever we're treating. That is the one, that's the medication they should be doing because it is the most cost effective. And it'll get disapproved because it's not on the formulary because they've made this other deal that if you use this drug, we'll get a rebate on that. And so that one will get approved. And so I've seen that a lot. And it just, until I understood PBMs and what has happening, I just couldn't, it made no sense to me why something that was more expensive was approved versus a cheaper option. And when I say cheaper, I don't mean lower quality. It's the same drug, or at least the same class. It's the same Cocoa Puffs. Yeah.
Yeah. But these drugs have been time tested, right? Years and years and years. They have been prescribed for whatever, and it is the most effective, and it is it has the most data on it. And but all of a sudden they can't because they made a deal
with this other drug got the deal.
And so this one could be pennies and the other one's going to be dollars. But they're going to shift them over to the one with dollars because they made the deal.
And where I saw this was Medicaid. I was when I was working in a Medicaid clinic, and it's almost 99% of our patients had Medicaid, and so I'd see it all the time on that. It was crazy. So, and I don't know what the behind the scenes was, but it just didn't make rational sense the way it was being rolled out.
It doesn't smell right.
On the end, it didn't smell right.
Yeah. It seems like it's almost kind of seems conspiratorial.
And it hurts care because these same patients who have no money, they would go to a pharmacy that, we'd send a prescription, whatever, to a pharmacy, and they wouldn't have the coupon. They wouldn't be armed with the knowledge that, it's cheaper to do it this way. And the pharmacy would be like, that's $62. And they're like, well, no, thank you. So now they've gone without care. I, as the provider, have no idea that happened until they come back for a follow-up and they're like, we couldn't fill that medication. I'm like, it doesn't cost that much. It's a $4 medication. Go to this pharmacy. And I'm not going to name the pharmacies, but there are some highway barons out there that are really messing people up. And so it was so bad that people were actually not getting care because of the cost of something when next door they could have gotten that medication.
Yeah.
So, because I want to shift to that real quick, because I think this is really, really important. So if you're an employer and just prescription drugs with your employees, and you're going to tell them, go here, and this is the price that you're going to pay with direct primary care.
Take this coupon.
So
this is the price.
If they have you guys, direct primary care, they have Well Life ABQ, that is what's going to happen with every time they need a medication.
Right. And in the analogy of the $62 medication, it was for an asthma medication. So now the child has an asthma attack because they didn't get their inhaler. Now they're in the ER. It's costing that, it's costing a bunch of money, but that employee, that parent is now out of work. Because the system completely broke down.
Whereas now what they're doing, what an employer is experiencing now with the system is when their employee goes to that place, whatever deal these nefarious, what do you call them? I wanted to say PB&J, but PBM.
Not quite that wholesome.
So these PBMs that are cutting all these deals, your employee may turn around and be paying $60, $100, $200 for something that could cost pennies.
Right. From my perspective, the insurance company, the PBM wins. The employer and the employee does not.
Yeah. And oftentimes it can be the case because, when you look at it, sometimes their copay, they're like, okay, well, this is your copay and this is what you're going to pay. Well, that's the actual cost of the drug. They just don't even know that they're paying 100% of the cost of the drug.
Yeah.
Which is their copay. Okay. That's fine. But when you look at it on a larger scale, a seriously large scale, when we're talking about drugs that are upwards of $3,000 a month for one person, okay, that is huge money. Big money that is getting kicked back.
So somebody has Parkinson's or something like that. I know that's, that could be $3,000 to $5,000. So there's options when it comes to that, even on these big time drugs.
Potentially, it depends on the drug. There's local pharmacists that are willing to create bins for larger companies.
Yeah,
and so
bins. What that means.
I think, can you explain it? It's like the cost for that company, that particular plan. And so a pharmacy can create its own bin for company X and say, okay, we'll help get these for cheaper prices. The bill goes to the employer, but they're not paying the inflated rate. Okay. Now, it doesn't really fix rebates, but at least it fixes inflated rates. And the employer is paying directly. And the pharmacist...
Now, who figures that out? If I'm an employer,
the pharmacist is just saying, this is the best price we can give you.
Right.
And, we have a baked-in profit, which they should, but you're not getting the bill later. You're not finding out later. You know up front what it's going to cost, and it's not inflated. And so the employer wins because they're not paying inflated price. The pharmacist actually wins because they're not having to file a claim and do all the paperwork behind that medication. They just get directly paid. And so it's a win-win-win.
I like that. And so for sake of time, we'll get into this last part. And we talked about this a little bit in the beginning, but I kind of want to go back to it. The choice and quality. Because I think this is and I know you had sent me a chart with AD. I saw that and I didn't really understand it. I saw ADD, ACC. There's like ratings when it comes to clinics and hospitals.
Yeah. So there is an organization called Leapfrog and they do a hospital safety grade. And they have the ratings and you can dig into it further. Like, why did they get this ranking? Like what caused them to get a D, a barely passing grade, and what causes them to get an A? And it has to do with infection rates and, how often people are bounced back into the hospital. So readmission rates. And there's all these metrics out there that will grade a hospital. And so then these hospitals, and these are local. So we have hospitals in our Albuquerque area that are A hospitals, and we have hospitals that get a D ranking. Which hospital would you like your employee to go to? Is the choice of all the hospitals important, or is it best to have the best hospitals important?
Yeah.
Thoughts, Angela?
Well, it's the hospital report card. I mean, it makes it simple.
Now, is there deals cut out in that arena that you know of, like where it would be a deal cut out with, like on the insurance side of things where you have to visit, because there's like Presbyterian Healthcare or whatever. I'm not picking on them. Lovely, we can name, all throughout the United States. But do they cut deals out with that where you can only go to this hospital? That's you go online, look, and you see it's D-rated, but it's like that's the only place your employer that you can go. Or are they still allowing choice when it comes to hospitals?
It depends on your plan. It really depends on the plan.
It just seems so complex.
In New Mexico, we have a bipolar system, which is
I love this
on many levels,
which is unique in a lot of markets. Not a lot of markets have this. As far as I know, I've only heard of one other market in Utah that it's like this, but they don't like to share their toys. We have two systems, largely two systems, two very large systems, and they don't play together in the same sandbox. They won't share their toys. So it puts a lot of
limits.
This or that.
It's power with the health insurance companies and lack of choice for the employers. And so it becomes about where people want to go rather than, quality or cost. It might come down to cost. I don't know. It just doesn't make everything on the level playing field.
No, that makes sense. So whenever we're looking at choice and quality, and we see quality, and then we're going to use the word value, I kind of want to end in this, and we'll go more towards your side of things, and then you can speak up if you want. But if I'm an employer and I want to create a win, that intrigued me, 30% savings. Can I talk to both of you? Let's say I have 150 employees. Can I bring you in an office with my HR person and us have a conversation? How does steps work with talking with each of you to figure this out? Because, it's 20, I may be coming into next year, 2022. So this is intriguing me enough. I need to know a little bit more about direct primary care. How can you help me with, savings on the insurance? What's the next step?
So, I'll end up in front of an employer and they'll start throwing insurance benefit questions at me. And that's not what first of all, I'm not an insurance broker. I'm not licensed to give advice in that field. And I tell them that. So I would bring in Angela to talk about that stuff. She is licensed for that. And then vice versa, she would be meeting with an employer and saying, here's all the bad news for this coming year, but I also have this other product that might not only help with cost, but it will help with access and quality and choice and all that stuff.
I hate to use the word product. It's not really a product. I mean, you're offering
service.
You're offering like authentic health.
It's very valuable and I love it. But at the end of the day, it's another product line, I guess. So is that the right term?
Because what you get compared to.
But you're right. It's a relationship business. It's a business of relationships. And we want that to happen. Right. We want everyone to have a relationship with their provider. It's like going back to the hometown family doctor.
Mm-hmm.
Yeah.
And that's what we're trying to, it's like that pendulum
swing.
It's
not a product.
And that's a good point to bring up is, for the most part, we work for all employers. Like we can provide value to every single employer in our city and beyond. But the one employer that we don't work for is that high turnover, that they really don't care about their employee population. They're in and out, they're seasonal, they're this or that. So we don't work for that because we are a relationship business. And we're in relationship not only with the employees, the patients, we're in a relationship with the employer. We have to do well for them. We have to perform. We have to keep their employees happy. So it's a win-win.
So steps would be, if I'm an employer and I have 150, 200 employees, I'm just throwing out that number, 40, 50,
It's whatever. A good number.
Yeah, 150, 200 employees. And I can have you guys meet and have a conversation. Is it that simple?
Yeah.
It's that
simple.
Without,
I don't have to go online and try to figure a bunch of stuff out.
So I have a company right now. It's actually a regional project. And so we're just a satellite campus for this company. And so we've been brought on by a different direct primary care clinic out of Oklahoma. And it's a humongous project. And so like they're having open enrollment now, which is usually like within a few weeks, like you have to open enroll and make your choices. But the direct primary care component can be ongoing. So if they don't enroll during open enrollment, they can enroll next month, the month after. They can enroll when they get the sore throat and they're like, oh crap, where do I go? I don't have a primary care provider. They can enroll anytime
with you.
They can enroll
anytime.
anytime.
$75 a month.
Right. So but the company has set it up that their employees can enroll at any point in the timeline. They don't have to just do it in their little open enrollment window. And so it can be rolled out differently. And then I have another company that they did their open enrollment, then they brought on direct primary care. And so we're enrolling that this month. Yeah. Last month. No, we're still in April. Are we still in April?
We are.
Yes. They're enrolling this month.
So insurance questions, want to switch over, direct primary care, probably switch them over to you, and then you could see if you can't answer it, then you'd bring her in.
Or vice versa.
Or vice versa. Yeah, cool. So I will get the email addresses of you guys, and we'll make sure we put that in the show notes and all that. Thank you. And this was awesome.
Thank you.
I appreciate you. Yeah, we learned a lot.
Thank you for joining us on the Albuquerque Business Podcast. And thanks to our sponsor, RigbyDigital.com. Make sure to subscribe and share, and go to abqpodcast.com. Get show notes, resources, and links to everything we talked about today to help you navigate your journey as an entrepreneur and business owner.